help you refine some of your thoughts and ideas. All right. So today we're going to talk about some initial diagnostic approaches when our patients have lower respiratory disease. We're going to talk about some secondary and tertiary level referral type tests. So, once you get to go, okay, I've done this, this, and that, and my patient is still blue, let me send it off to a place that can handle that. In terms of our therapies, we'll talk about what we often do in general practice and then what ends up happening when we move on to referral practice. All right. So get a patient that comes in, they may be coughing, having difficulty breathing, any of those things. So, we look at our signalment, see if there's anything breed associated that would make us think, oh, I need to consider these additional conditions other than the usuals. We're going to get a good history. We want to find out, has the patient got a history of vomiting, for which maybe they aspirated? Did the owners give any medication by which that patient may have aspirated? Did the patient, get bumped by a car? Anything that might have led to the development of the clinical signs. Did it just start? Has it been going on for a while? All of those pertinent questions. We're going to do a good physical. We want to auscultate all those quadrants of the lungs. We want to listen for crackles. And we want to pay attention to our patient's respiratory pattern, because just watching their chest, expand and contract helps us to determine, do I think my patient is dyspneic, or are they struggling to breathe, or do they have a normal breathing pattern, or are they expiring, but at the end I see their abdomen contract. So do they have an abdominal push? Is there something that in their breathing pattern I can recognize something abnormal? Because that abnormality is what's going to help me go, this is what I think is going on. Let me pay close attention to this. So oftentimes, part of that minimum database for these patients is going to be taking thoracic radiographs. So that helps us to see what's there. If I hear pulmonary crackles, I should see evidence of pulmonary edema on my radiographs. So, everybody sees this one. You guys allergic to each other? Oh, you're allergic to me. Oh. You still get a test next Friday. Oh, yeah, you can't sneeze me away. Additional diagnostics, our CBC might be an indication that our patient has something infectious in nature, so we may see an elevated white blood cell count. If there's something allergic in nature, we may see an eosinophilia. So we may or may not have clues on our CBC. Usually the serum chemistry is unremarkable in these patients unless they have some other condition that is separate from their respiratory disease. But we tend to do the chemistry just to kind of complete that minimum database. Oftentimes, if our patients are young and we think that infectious diseases may be involved, then we may do fecal flotations or fecal Bayermans to look for things like lungworms. So we're looking for those clues as to why our patient may have some respiratory disease, and the least invasive are the nicer ones to do. In some cases, we may just deworm for the possibility. I have a 2-year-old dog that's got a cough that's inexplicable, and I don't really see anything on x-rays. I may deworm it for lungworm even if I don't have anything on my fecal Bayerman. So when in doubt, deworming. If the clinical signs resolve after that, you go, hey, maybe it was really lungworm. Other things we want to consider, especially living in the South, heartworm testing is going to be a big one. So any dogs that come in coughing, we're on that heartworm history. Have they been tested? Are they on prevention? Or have they been living out in the backyard and not had a heartworm prevention since they were a puppy? We talked about in recorded lectures, virus isolation. So if we have anything that we think is lower respiratory, you might get some of those puppies that have a Bordetella pneumonia because they're already immunocompromised. Another thing to consider in puppies is as we deworm them, if they have a heavy worm burden, they can actually have a verminous pneumonitis. So sometimes you'll actually see puppies develop respiratory signs right after you deworm them. So just kind of keep in mind that that may be part of the process. You know, when you think about your lungs life cycle, some of that is a tissue life cycle where they move into the lung parenchyma and then they end up in the airway and they get coughed up and swallowed. So we have to remember that those are also possibilities. Now the NT-proBNP. All right, this is a test that's designed to help us differentiate whether our patients have a respiratory condition or a cardiac condition. It's relatively sensitive for cardiac disease, and if your patient has a normal NT-proBNP, let's say you take a radiograph and you got a short squat Yorkie and its heart looks huge on the radiographs. And you go, well, maybe it's cardiac. And I'm not sure, and I'm freaking out right now because this is the first case I've seen. He's in respiratory distress, and I don't know if I need to treat his lungs or his heart. So you run an NT-proBNP. If the NT-proBNP is within reference range, it's not his heart. That's about as helpful as that test is. If it's his heart, then you can go, okay, and treat for congestive heart failure. But sometimes you get patients that have an elevated NT-proBNP that aren't actually in congestive heart failure. So then you're treating for that, but then they still have a cough, and then your clients are very confused about everything. So I can say that this test is helpful if the measurement is below the reference range and you have a coughing dog. Say it's not his heart. All right, moving on. So oftentimes in practice, we end up managing or treating for the treatable. So depending on the severity of the condition, the patient just has a cough. We do cough suppressants and dewormings if we think there's something infectious, and just kind of minor therapy. Some people will throw antibiotics at it, even though it's probably not a lower respiratory infection. And it's when the cough gets really bad, or it's when the cough, or when the patient starts to become dyspneic or cyanotic, that we end up having to do more diagnostics, and it's the patient's condition dictating us having to do additionals. So start out with some RADs. Now, I know you guys usually get like the worst case scenario bronchial patterns as your examples, and it's important to know the criteria for those so that you can say, okay, am I seeing all the things that fit with this? Most of your bronchial patterns are going to look like this. They're like, yeah, okay, what am I seeing? From far away, you're like, I want to call it interstitial. But then up close, you're like, wait. Oh, I see parabronchial puffing, and here, and way out in the periphery, where I shouldn't see parabronchial puffing. I should be able to see the lines of the airways on the main stem bronchi. I shouldn't be able to see the highlight of this way out in the periphery. Question. Let me give you a good one. Right there. There's another good one right there.
What is that?
Got it? Yes. But oh, it keeps going. It's a very sad mouse. So right there, you see that little guy?
I'm going to take your word for it.
I'm just going to all my x-rays.
I shouldn't be allowed to interpret my
Well, like I said, this is what your patients typically are going to look like. They are not going to have the horrendous bronchial pattern that everybody's like, oh my gosh, that's a horrible bronchial pattern. That's like those are your 10%ers. Everybody else has this kind of subtle change. Yeah.
So on the actual X-ray machines now, you can like do the contrast up and down, like with the mouse. Does that help see those, or would that help, or is it just something you just have to use to somewhat understand?
Some of this is you got to see a lot of it. You actually have a whole bunch of bronchial pattern going on in here, but you also have summation of your tissues with the cardiac silhouette and the ribs. So the more that you see it, and the more that you look for those characteristics, the easier it gets for you to see it and be like, oh no, that's bronchial. Because yeah, from far away I can go, okay, lungs look kind of gray, maybe that's interstitial. But I can zoom it in and better appreciate them. The one thing with digital radiography is that we see everything a lot better. So sometimes you might actually see some things out in the periphery, and depending on how your contrast is set up, it can actually make things stand out more than they should. So you got to take it with a grain of salt. It's nice that we have the ability to send these out and have a radiologist read it. So if you're like, yeah, I think this is a bronchial pattern and my patient is coughing and has some wheezing, that's going to go along with it. And if your radiology report agrees with that, then you're like, all right, I found the bronchial pattern. And the more that you practice that process, the easier it is. Interstitial. Like everything's, yeah, this is like worst case interstitial. So you have a diffuse nodular interstitial pattern. So this one stands out and you're like, okay, I can't miss this one. Most of them are going to be that kind of subtle, boring interstitial pattern where you're just like, okay, everything's a little grayer in the background than it should be. We have some additional nodular interstitials. We often see nodular interstitial with inhaled fungal disease, so what's going to be the most common? In the lung. Aspergillosis is in the nose. Blasto. So blasto in the lungs. And it gives you that fuzzy, they talk about, you'll have different descriptions of the interstitial pattern, but nodular can have multiple meanings. So this is a nodular pattern, but this is also a nodular interstitial pattern. What's this? What do you think that nodular interstitial pattern is consistent with and could be caused by? Okay, so this is an emphysematous bulla because it has air in it, but it has a cystic type structure, but it's an emphysematous bulla because it's air filled. What would cause that? COPD could lead to something like that. COPD, asthma, anything infectious? Ergonomist, somebody said. So certainly signalment, patient's history, indoor, outdoor, cat that likes to eat things on the ground. All right. Now, alveolar pattern. For me, it took reading lots of radiographs with an alveolar pattern for me to finally go, I got it, all right. We'll talk about trees in a snowstorm. That didn't make any sense to me. I was just like, I don't know, I don't get it. I just had to see it multiple times. What made sense to me was I can see an airway, but I can't see the wall of the airway. And that's what helped me go, I got alveolar now. I see the airway, I can't see the wall that defines the airway because there's fluid in the background that's the same density as the wall of the airway. So if I can't see the wall of the airway, that's going to be an alveolar pattern. Let's go back. This guy. We have an interstitial pattern. I can still pick out what I think is a wall here. Now, it's not zoomed in, it's not the best contrast, but I can pick out airway walls here. So, to me, this is interstitial in nature because I can see the airway wall. It's not alveolar because of that question.
Wouldn't your auscultation also, like if you're auscultating the thorax, would it also tell you need to be looking for something on the radiographs instead of just saying, oh, thorax looks normal?
Your auscultation should be a clue, but I mentioned pulmonary crackles as a sign for pneumonia. But what if you have pulmonary crackles because your patient has chronic bronchitis and COPD? So I can't just listen to them and say, oh, this is the pattern that I expect. Not always. Now, if I'm listening on the right side in the cranial-ventral quadrant, and I hear crackles, and I don't hear pulmonary crackles anywhere else, that is one time when I can predict that I expect to see something like this, like an aspiration pneumonia. So my right middle lung lobe should have some degree of consolidation on that radiograph. I had a fabulous one, and I got to download it and put in the presentation. Always works out. All right, effusions. You cannot hear fluid in the chest. What do you hear when you have pleural effusion? You have muffled heart sounds. Oftentimes, if your patient is in a standing position, more of your fluid will pool ventrally, so sometimes your dorsal lung fields will actually sound harsher, and they'll be less muffled. But when you go to listen to the heart is muffled. But you got to make sure your patient's in a standing position. If the patient's laying on his side, and you say, I can't hear his heart, he's a big, deep-chested dog, it's probably that his heart is flopped to the other side. So you got to get that guy up in a sternal position and listen to the heart where you're supposed to hear it, and if the heart is still muffled, then that's going to be our clue. You start going, oh, okay, I can't hear anything, so there's either a mass, there's fluid, either in the thoracic cavity or in the pericardium. Half-page pulses, if the pulses are normal otherwise, then it's probably not a pericardial effusion. Now, if your patient has this much effusion and they're dyspneic, I probably don't want to take a radiograph first. I'm probably going to treat that patient first. So I'm going to perform a thoracocentesis. But if I'm not sure, I can take a radiograph. I just don't want to stress out my patient, try and get the perfect radiograph. And then I'm like, hey, we got great radiographs. So unfortunately, Fluffy didn't make it. So sometimes you got to treat for the treatment. Same for pneumothorax. You see that there's separation between cardiac silhouette and the sternum. That would be classic. This is leafing of our lungs in the background. So we need to tap this cat. What the deuce is this?
Before we go back. Okay.
You got it?
Ventrally, kind of by the apex of the heart, cranial to the apex of the heart, a little donut-shaped thing.
Sorry. That could be any number of structures. It may be part of the costochondral structures. It may be that, and I don't have the VD to make a comparison. It could be that one side is more aerated than the other. So you're just seeing more airway structures from the other side. Could be adhesions, fibrous tissue. Could be a puncture area of this cat, a big dog. So it could be any number of things. But I would want my orthogonal before I pass judgment on it. Oops, sorry. Brain radiographs. All right, so what about this? What do you see out here? What's this? Way up here? Okay, so these are borders of the lungs. can also see them out here. Are they attached to, okay, so they aren't completely expanded, so what does that tell you about what's here? No. What's out here? You guys are, now, instead of guessing all of this, now you have to read the radiograph and say, what do I see? Because I can't guess what's wrong. All right, so we got some fluid that's causing contraction of the lungs, so there is a pleural effusion. Then what's going on here? Can you see the cardiac silhouette?
No.
So the cardiac silhouette is obscured. All right. What do you see here? Okay, the trachea is dorsally displaced. Now you have a diffuse interstitial pattern. You have some evidence of pleural effusion due to lung lobe leafing. You have dorsal displacement of the trachea and obscurity of cardiac silhouette. You have read your radiograph. Now, what would I recommend diagnostically from here? I would want some additional imaging because the trachea is dorsally deviated, so if I go to blindly tap this, I might actually hit the heart. So I want some additional imaging before I do anything to this patient. It could have a mediastinal mass, it could have a pericardial effusion, it could have very severe dilated cardiomyopathy with pleural effusion. I don't know, but I have to read the radiograph and say this is what I can see